Good evening and welcome to the RowanSOM Alumni Association's monthly webinar series. I am Tom Cavalieri, Dean of the Rowan University School of Osteopathic Medicine. We are pleased to continue the alumni webinar series, which began a little more than a year ago with our 10th program this evening. Tonight, our expert panel will discuss one of the most common but yet complex health issues that affect so many of our patients: chronic pain. Tonight's webinar, Chronic Pain, Evaluation and Treatment Approaches, features a discussion with our all-alumni physician panel, who I will introduce in a moment, who will cover the causes of pain, factors and conditions that impact treatment, medication usage and potential safety concerns, and how to manage daily pain. Here at RowanSOM, we are fortunate to have a very talented team of physical medicine and rehabilitation physicians within our Neuromusculoskeletal Institute and one of the region's preeminent substance abuse programs to treat addiction. We have ongoing research programs and service grants to support the school's substance abuse program, including Narcan training and pop-up clinics that are held in communities that have high rates of opiate addiction. I know Dr. Taylor will share more information about this with you this evening. The format of the webinar includes a moderated panel followed by a Q&A from our attendees. And for tonight, we have allotted about an hour for this program. As a reminder, you may submit your questions at any time in the chat so they can be shared with the panelists during the session. It's now my pleasure to introduce the presenters and participants to get our program started. First is Dr. Tracy Tamburello, SOM class of 1999. She's a board-certified family physician, having completed her residency at St. Barnabas Healthcare System. She has been practicing family medicine for 20 years, including several years in a multi-specialty group, followed by service with the National Health Services Corps, caring for patients in medically underserved communities. She currently practices in corporate health medicine in the central and northern New Jersey regions, but has always kept her foot firmly planted in community family medicine. Her special interests include holistic preventative care, wellness, and promoting mental health initiatives. Dr. Tamburello will serve as the moderator for this webinar. Tracy, it's great to see you, and thank you.
Thank you.
Dr. Natalie Hyppolite, RowanSOM class of 2013, is triple board certified, having completed a residency in physical medicine and rehab at Zucker School of Medicine at Hofstra University, and OMM NMM +1 residency right here at RowanSOM, and a sports medicine fellowship at VCOM, Virginia Tech. She currently serves as the medical director for the Cox Medical Center Branson Acute Rehabilitation Unit and attending physician for the Department of Physical Medicine, Rehabilitation, and Sports Medicine. There, she combines all three of her specialties in a thriving outpatient, non-operative musculoskeletal practice. Natalie, welcome home.
Thank you.
Also with us is Dr. Lanvin Taylor, RowanSOM class of 2009. He is a board-certified physiatrist and graduate of the Physical Medicine and Rehabilitation Residency at Temple University in Philadelphia. Dr. Taylor serves as a PM&R specialist with our Neuromusculoskeletal Institute in Rowan Medicine, and he is an assistant professor in the Department of Physical Medicine and Rehab. Throughout his career, Dr. Taylor has contributed to his field through formal presentations and publications. He has lectured on health issues such as lymphedema, stroke syndromes, corticobasal degeneration, and published an article on orthotics in Current Diagnosis and Treatment, Physical Medicine and Rehabilitation. Lanvin, and we're happy to have you with us as well. Finally, I'm pleased to introduce student Dr. Alan Chung, a member of the RowanSOM class of 2024 and an officer for the RowanSOM Student Council, who will assist with the Q&A portion of the program. Panelists, I want to thank you for lending your time and expertise this evening to address this important topic. I am amazingly proud of all of you. I remember all of you as a student and so proud of your accomplishments. So thank you again. That was Dr. Chopra calling me. You all remember Dr. Chopra, okay? Anyway, thank you for being with us. And I'm going to turn this over to Tracy Tamburello, who will be our moderator. Thank you.
Thank you. Thanks for joining us this evening, everybody. So we're going to talk about chronic pain, which is a pretty big topic, but we're going to try to hit some important key points, and hopefully it'll be informative and helpful. Now, starting out with a little bit of background, chronic pain is a very prevalent problem in the US. According to CDC and National Institutes of Health data for 2019, approximately 20% of adults had experienced chronic pain at some point during that year, with a cost of about $635 billion. So, you know, that encapsulates doctor's visits, treatment costs such as physical therapy, medications, loss of productivity and work time due to chronic pain. So it is a very prevalent condition. What is chronic pain? How do we define it? A couple of prominent definitions. One is 3 to 6 months from pain that lasts for 3 to 6 months from the onset. That's the one most commonly used. Some researchers will use pain that persists for 12 months or greater. Those are a couple of little working definitions there. There are a few types of pain. So it kind of putting them into 3 general baskets. One type of pain is what we call nociceptive pain. So that would be due to inflammation or tissue damage. It's usually localized. It's usually quite consistent. An example of that would be somebody has a misstep off of a curb and twists their ankle, or somebody slips on ice and hurts their back. That's that type of pain. Then there's what we call neuropathic pain. That's more due to nerve damage or what we call entrapment, where the nerve is kind of squeezed or pinched. So something like sciatic pain or diabetic neuropathy, when people have pain and tingling and numbness and burning in their feet due to diabetes as it advances. Carpal tunnel syndrome would be another example of that type of pain. Then there's central pain, which is more widespread pain, often associated with mood problems. Things like fibromyalgia can sometimes fall into that area, where it's thought that maybe there's a threshold or a set point for pain that might be lower in some people, that might be more predisposed to that type of pain. So what I'm going to do is I'm going to turn it over to our panelists, and we'll get some expert information about evaluation and treatment of chronic pain. So I will, with that, I'll hand it off. Who would like to get started first? Dr. Hyppolite or Dr. Taylor?
Sure. Typically, when patients get to, somebody like myself, they've already gone through their primary care physician. They've probably seen a lot of other different specialists as well for their pain. So we're kind of the last resort sort of physicians, when, that doesn't always need to be the case. I think it's just because of a combination of a lack of maybe access and a lack of information about what's out there to help people treat their pain. In my practice, in terms of chronic pain conditions, I'd say the top ones that I see most often are related to either osteoarthritis, which is your wear and tear type arthritis. It does not include rheumatoid arthritis, which is different. That's autoimmune, where your body's pretty much attacking the joints themselves. The second would probably be low back pain from any source. Sometimes it's a work injury, sometimes it's, they don't even know where it came from, and everywhere in between. Sometimes it's trauma from a car accident. And the third is probably sports-related chronic conditions that just didn't heal right. So we're talking anything from an ankle sprain to tendon injuries or things of that nature. So I'll let Dr. Lanvin or Dr. Taylor speak.
Good evening. One of the things that I would say that is unique about our practice and our program we have at the NMI is we have a practice that has a dual arm in recognizing that there is an inherent risk with prescribing opioid medication for chronic pain conditions. Also recognizing that that's not the only modality that we use. That's one avenue in, kind of a treatment program that we can have for people, and is appropriate for certain patient populations. But being that that particular type of treatment carries an inherent risk of, dependence and or abuse, there was also an arm of our program there that addresses substance use disorder. It was one of the things that when I was planning some of my career goals, I thought was remarkable about coming into this practice, because for most of the physicians out there or people who have a little bit of experience or have seen how things kind of end up going is, what do you do when you have a patient that might have been a pain patient, but also has coexistent substance use disorder? And the existing mantra was to discharge them and give them a list of other practitioners they could potentially see for not being in compliance or not being able to follow what the parameters were for the population. But ultimately, what that ends up meaning is that now you have somebody who is in need of treatment for two things, and they're kind of caught in the wind. So when I had initially come to the practice, when I understood that that was something that we had the infrastructure set up for, because infrastructure is a big part of a lot of this moving forward, as governing bodies have mandated more and more supervision and oversight. A lot of practices that had been doing chronic pain have kind of been going to say, well, see pain management, or have kind of been deferring to other practices. And that's why I feel like now we're starting to be able to kind of manage pain and substance use disorder in these multidisciplinary comprehensive clinics like we have at the NMI.
Yeah, it's very important because, especially, all of the news that everybody's hearing about the opioid crisis. A lot of times at some point in treating chronic pain, an opioid might be needed. Of course, we try to start low with a dose and move up slowly if we need to, and then try to get people connected with other treatment programs that can hopefully carry them through, the pain process, and hopefully get their functional capacity, significantly improved. And, as a family doctor, a lot of times patients, due to time constraints or cost or availability of pain specialists, they just really don't have access. So a lot of times there's a shortage of pain medicine physicians. So that's where, as primary care physicians too, we try to use a lot of other modalities physical therapy, home exercise programs, OMT, or osteopathic manipulative medicine and treatment, where we can help people achieve at least, if not a complete pain-free state, at least significant improvement. So, yoga, I often try to get patients to engage in that, because for somebody who's got chronic back pain problems, which I've had, that seems to help me significantly. So there are so many different treatment options out there that can be combined to fit a specific person's needs. Some people have done great with acupuncture. Sometimes weight loss is a very helpful thing. Even just a few pounds can help back pain or other types of pain conditions. So, I think I'm sure that you have both used a lot of different modalities like that in your practices too. That using the osteopathic manipulative medicine, I'm sure both of you are doing quite a bit of that. So I think those are some really good things that people can take advantage of, and try to take little pieces and combine different types of treatments to develop a program that fits an individual person's needs.
Yeah, I think one of the key things, just like you touched on, Dr. Tamburello, is, when treating chronic pain, it's not a cookie cutter algorithm, like,
Right.
somebody walking into the emergency room with a stroke or a heart attack. Those you want definitely on an algorithm, because, there are critical, organs that are at stake there. But when it comes to the neuromusculoskeletal system and treatment of chronic pain, it really is an individualized program. So one person's back pain is not going to look the same or be treated the same as another person's back pain, even if the mechanism may have been the exact same thing. So we, as physicians and specialists alike, have to kind of work collaboratively with one another. So say if I see somebody's family physician prescribe them physical therapy, and then the patient comes to me and they say, well, I'm still having hip pain, like it didn't help, it made it worse. It's like, well, did physical therapy make it worse, or is there another component of your pain that isn't being addressed, such as, a biomechanic issue that's resulting in what we call somatic dysfunction in the osteopathic term, meaning something that is dysfunctional with a particular body part and not causing it to function in the appropriate way. So that's where something like osteopathic manipulative treatment, which is a hands-on, technique and modality that we can use to address that specific area, that would hopefully, also treat their pain complaint or condition, in addition to what's already been tried before.
Yeah, and kind of piggybacking off what Dr. Hyppolite said, it's also important to have a discussion about goal setting and what we're looking as a treatment team to get out of this. One person's goal might not be another person's goal. If I have a patient who is on a little older side of things and wants to run a marathon, that might not be something that's a realistic goal, and we're not going to be able to get and achieve function. But what may be an appropriate thing is to be able to, walk around the park with their children or their grandchildren, or walk their dog, or engage in some type of activity that's gratifying for them in that type of way. At the same time, sometimes we have to look at, and I encounter this, I'm sure you all encounter this, where you have somebody and they may have a lifestyle or a job that's just not consistent with their biomechanics anymore. And having a conversation about that, which can be difficult, but understanding that if you continue to go down the path of trying to treat the job, when the person's physiology can't handle it, it's bailing water, so to speak, for lack of a greater analogy, out of a boat that's just taking on water. and having some of those difficult conversations about, just goal setting and expectations.
Mhm. Yeah, there was one topic that I know we wanted to get into a little bit more, which were kind of the risks and benefits of opioids and prescribing those types of medications. So, Dr. Taylor, did you want to discuss that a little bit? The kind of the risks, the benefits, the pros, the
Sure.
cons?
Sure. So I'll start with the benefits, because I think that's why we have these medications in our armamentarium to be able to be used to help our patients. So if I'm walking across the street and I get hit by a bus and struck by lightning, that I think everybody can agree would be something that would be particularly painful, 10 out of 10 pain. And before I think you could even really assess me appropriately, if I'm still conscious, getting my pain under control would be important, and getting it under control quickly would also be important. And one of the things and the advantages and the benefits of our opioid medications is that they work on the mu receptor, and we have mu receptors in a whole bunch of different tissues. Okay, so that's how I kind of understand it, and that's why they work so well and so powerfully. So we have them in the brain, we have them in our spinal cord. So what happens is you take the medication and it improves pain, but you take the medication and it also improves anxiety, and you take the medication and it works on all of these other tissues that have these effects downstream. One of the other kind of the other side of that coin is that you have it in every tissue, or in a whole lot of tissues. So now, if you're using it chronically, you can have constipation. If you're using it chronically, or if you're using too much, you have them in your respiratory center, and there can be, it can reduce what's called your respiratory drive. And we all need to breathe, because breathing is one of the most fundamental, airway, breathing, and circulation, they say, is one of the most fundamental kind of components of living. The other thing that makes them tricky is that, so we have a kind of natural opioid system that works in our body, and these are the endorphins. And they work as part of our reward system evolutionarily. So it's set up to be ingrained and kind of work collaboratively with things that promote survival. So you work hard and you are patient, and you're able to, from a primitive standpoint, obtain food. You eat that food and it's a reward for you, and you get that dopamine surge. Well, those medications over time can kind of hijack that drive, because they're receptors, or there's activity in those areas of the brain that promote reward and benefit. So that's where you start to get into the issues with abuse, because what people are chasing is that reward system that's in a lot of ways responsible for so much of the advancement of human life and life in general, and in terms of how nature works.
Now, what types of non-narcotic or non-opioid medications do you also use in your practices?
Yeah, and so I start out with that. So at one point, you were alluding to different types of pain. So the first thing I try to figure out is, okay, so what type of pain is this? Is this neuropathic pain related to a nerve injury, which can actually give you pain distant from the site of injury? Is this a inflammatory issue? Is this, so I try to figure out what type of pain it is. And then there are medications that work better for like nerve type pain, or work better for inflammation or an inflammatory condition, particularly as a first line. So if I have somebody and they have a herniated lumbar disc, one of the things that I would do before putting them on an opioid. It's say, let's hit this with a powerful anti-inflammatory, AKA steroids, or let's hit this with a powerful anti-inflammatory, AKA like an NSAID, like a Mobic or a Celebrex or a medication like that. That is prescription strength, but is not an opioid medication. Activity modification. So saying like, if somebody, for example, breaks a long bone, non-weight bearing, crutches, things of that nature, taking time off of work, which is a big thing that a lot of people don't necessarily want to do, but taking the time to counsel and say, with all the advances in modern medicine, a bone still takes, 6 to sometimes 12 weeks to heal. And all we can do is prevent it from, protect it during that time and make sure you're eating and we're optimizing, our kind of, our ability to heal.
Mm-hmm. As far as for Dr. Hyppolite, you do some other treatments such as prolotherapy and the plasma-rich, platelet-rich plasma. Do you want to discuss that and touch on that a little bit as options?
Sure. Those are additional modalities that we treat. And just to piggyback a little bit off of what Dr. Taylor and Dr. Tamburello were talking about earlier about, non-steroidal anti-inflammatories being, first line before opioids and everything, during the whole phase of this, treatment process, we are doing what we're calling risk stratifying. So if somebody has, significant heart conditions or kidney conditions, liver conditions, uncontrolled diabetes, we're taking all those things into account before we say, okay, we're going to go this route versus that route. So those are things that we think about as well. In regard to procedural, options for chronic pain, there are, regenerative options called prolotherapy and platelet-rich plasma, which myself and many others use in various settings. So prolotherapy is a combination traditionally of normal saline and glucose or dextrose solution. Some places they add different components as well, and that's just fine. But for the most part, those are going to be the two main components of that. While platelet-rich plasma is sourced from the patient's own body, so it involves a blood draw, and then we spin it down in a machine to get the concentrated part of platelets, which contain all the healing factors and growth factors that are in the body to heal a certain area. So an instance where, either one of these could be used is if somebody has, chronic Achilles tendinosis or inflammation like that just hasn't resolved in the Achilles tendon. And they act as injectable irritants to that area, not to be mean or, try and make people to be in more pain, but it's really to signal the body that this area is still a problem, that it hasn't adequately healed yet. So it's almost like creating a re-injury to signal all those cells to come down and heal and kind of fill in those gaps and, reinforce the natural integrity of the tendon itself. So, I use a lot of it here. I mean, I just did some procedures this morning. One was a repeat patient who I hadn't seen in a while. They were a younger athlete. Their goal was to get through baseball season. I had treated them late fall. They got through baseball season, 100%, no pain. They graduated from high school and went to work and lifted a bag of something that was way too heavy and, re-injured their shoulder. So they didn't call for, me to take a look at it or anything like that. They're like, hey, can you do PRP on me? Like before you leave the office. So, because they already knew how much benefit they had gotten from it before, and now treating a new injury a lot sooner than we got to the old one, we can get ahead of it and start the healing process a little bit sooner rather than later. So that's one of the advantages of it as well.
Have you seen that those modalities are being covered by insurances?
So on a whole, no. Some insurance plans, they vary so vastly. Some do. But what I counsel all my patients on is that, once you've had it done, take your receipt to your insurance company and call them up and say, hey, I had this procedure completed. I feel great. I just saved you 20 grand from not having surgery. Can I get my few $100s back?
Mm-hmm.
And a lot of people have had great success with that, actually. So that's what I advise until, insurances start catching on and start covering it more completely.
Right. Now, what would you say are kind of like the top 3 pain conditions that you treat in your practices? We did mention, lower back pain as being a very common one. What are some of the other major conditions that you see on a regular basis?
I would go with fibromyalgia and osteoarthritis.
Mm-hmm.
And that kind of also plays in with some of this, just the spine stuff in general, is that you end up having, an osteoarthritic component but maybe a discogenic component. And when I'm, for the non-physicians out there, what I'm talking about is whether it's an issue where you're having some more wear and tear on the bones or wear and tear on kind of the cushiony aspects of the spine, when I'm talking about that. And then, fibromyalgia, which ends up being this kind of intersection of probably a couple of things. And I think that's why a lot of times when we're not sure what something is, if it doesn't fit into a nice, kind of diagnostic box, we have this area of where we say, well, it's a hypersensitivity syndrome. There's, a mood component of it, perhaps some sleep disturbance, but it may be caused by, from the literature that I've read, it may be caused by other different things in different people. And that's why different treatments in different people can kind of work at getting to, and I think as more research is done, and like anything else in medicine, there's criteria, and as they start to be able to come up, or we start to be able to come up with a criteria, and we can subcategorize into type A or type 1, we may be able to better kind of tailor, no pun intended, our treatments to that particular disease process.
Right. Now, some people have looked into medical marijuana, which has become, I guess, more available and maybe more popular. Is that something that that you use in your practice, or refer people to the medical marijuana dispensaries for, to the physicians that are on the registry to prescribe medical marijuana? Or do your patients ask about it?
So, and I'll go first with this one. So yes, patients ask about medical marijuana or cannabis, I think, which is the term that's in vogue at this point. We don't prescribe any medical marijuana at this point. What I think the legalization or the what's a better word for me to use rather than legalization, but the liberalization of our stance on marijuana is going to do is allow us to conduct some robust studies. One of the things we're still trying to figure out is, I think that the data is out where there's certain conditions where, yes, cannabis is remarkably effective. If it's chemotherapy associated nausea, if it's some pediatric seizures and things like that. There's some other conditions out there that I don't think the data is fully out on yet. And so what we will ultimately end up doing is, we don't necessarily stand in anybody's way and saying that, you can't do this. But we would say, one, if you are going to partake in medical cannabis, that you should, get a card. And you should get it from a dispensary so that you know what you're getting. What we're seeing sometimes is we have some of our patients, whether it's in the substance use arm of the practice or the, the chronic pain use of the arm of the practice, you never know, like when, and I, at the risk of sounding old, when I was a kid, right? It was kind of like you weren't gonna get marijuana that was, for the most part, unless your friends did it, laced with something else, because it would cost more money. It didn't make economic sense. With the emergence of fentanyl and some of these other drugs being so more popular, they could just be sitting on a table, getting bagged up with something else, and become a contaminant. And so one of the things is, you don't want to get that as a contaminant in your system, because fentanyl can be deadly. And then two, you don't want that as a contaminant in your system, because if it comes up when we are, monitoring you, then it's something we have to speak on and talk about, and it could end up derailing your treatment. But like I said, I think as more robust studies are done and we, get like FDA approval, like anything else, that could be something that I think we'd have more credence in. I also, and this is less evidence-based, but more a personal thing, just think that we need to come up with a better route for marijuana or cannabis. I mean, you don't smoke your high blood pressure medication. You don't smoke your diabetes medication. I have an issue with smoking as a route of taking a medication, because it's still doing tissue damage and causing, inflammation in the lungs and the oropharynx.
Yeah, and there are other routes, for the medical cannabis. It can be added, to baked products.
They're gummies, they're drips.
Gummies, right, right. The oils, that you can put on your tongue. So there are, other routes that people are using for that. Another question that we had was, trying, if somebody's been on, let's say, an opiate, or let's say, a steroid, how do you go about getting that patient titrated or slowly taken off of that medication once you've either gotten the results that you want, which is getting improvement in the symptoms, or let's say it's not working for the patient, or they're developing tolerance. Can you touch on that a little bit?
Sure. So, and I don't want to step on your toes, Dr. Hyppolite. If is it all right if I take this one?
Oh yeah, go for it.
So, usually I'm not a rheumatologist. So usually I don't have anybody on steroids for more than 2 weeks. Maybe 3 weeks. Sometimes the patient may come to me and they may have been on like a smaller dose of steroids, like a Medrol dose pack. And typically for me, I'll say, the spine's this whole big thing with big bones, and, it's moving all the time. And every time you transmit energy from your lower body to your upper body, it's got to go through the spine anyway. So let's go ahead and hit you with a little bit more. But the taper or the wean is generally included in my first prescription. And then what I a lot of times will do is, even after I do like a steroid and I wean, I'll say, you know what, here's some Mobic to take for another 2 weeks, just to prevent, which is a non-steroidal anti-inflammatory, just to prevent the fire from coming back again, if I can get some good results on that. Mm-hmm. Now, if we're dealing with a patient and we decide, so it's kind of a loaded question. Or not that it's a loaded question, but I have to answer the opioid question in 2 ways. So the first answer is that if I'm prescribing opioids for a acute problem, and so an acute problem is something that I think is going to last days or maybe, a week or something like post-operative, I am going to think about 3 to 7 days of having pain that requires an opioid. So, at 3 to 7 days, most people are by and large going to be able, if it's an acute problem and there's some healing and things like that going along, and swelling is going down, can then be transitioned to like a non-steroidal or a medication, like or a non-steroidal, a Tylenol, icing this thing aggressively and going from there. Now, what's going to end up happening is, let's say you're somebody who, or one of the unfortunate patients that have had 3 back surgeries, and, you're still having significant back pain, that despite having the 3, back surgeries that you have, then yeah, and in order for you to be able to function and have some quality of life, we're not likely going to get you down to 0 out of 10 pain. We're going to have a conversation that talks about what our goals are and function. We're going to use some opioid medication, but we're also going to use other medications, particularly if we talk about it's a different type of pain, to help with that. So we don't build up tolerance so fast, and that we're controlling the pain from a different aspect. Now, what we have to be careful of, and this is what I feel like you used to see maybe 15 years ago or so, or pre 15 years ago, is that not being able to get off the merry-go-round. So if 5 works, go to 10. If 10 works and stops working, then go to the 50. And the problem with that is, and some of us, we probably all seen this, is that at some point you can come in with somebody taking, when I'm using these numbers, I'm using morphine milliequivalents, which is just a measure of how much opioid you're taking, is that you can see the patient that comes in taking 200 morphine milliequivalents, and they're still in 10 out of 10 pain because the body has just gotten used to it. So having conversations about that, rotating to maybe a different opioid, sometimes tapering off.
Right.
And saying, in order for these medications to work for you, we might have to try something different for a while. Or, listen, if we got to save a little bit of room, like this will happen sometimes where I have a patient and I need to taper them down because they want to get, shoulder surgery. And the surgeon says, well, I'm concerned about being able to treat your pain in the OR and post-op. So we need to get you down to a certain amount so we can do the shoulder surgery. So those are all some of the conversations that we have.
Dr. Hyppolite, you mentioned that you do osteopathic manipulative therapy in your practice. Can you talk about some of the chronic pain syndromes that you see and how you apply the OMT there?
Sure. I see a good deal of low back pain. Like, for example, I had a patient this morning again who has had chronic back issues since they were, a teenager playing sports. They're now well into their, midlife and have had flare-ups here and there, more recently from like water, activities that they tried to do. So, what I did was I, did a generalized assessment, make sure that their nerves are functioning appropriately and communicating with their brain, because we don't want to miss anything, going on that's more imperative to treat, like, a spinal cord issue or anything like that. And then, I put them through a series of maneuvers and tests to see where their motions are moving most freely, and where they are restricted. And depending on, what is more comfortable for them, I treat either into the restriction or I treat, into their ease. So for the med students, listening, that is the difference between direct and indirect treatment modalities. And then after that, you really want to progress and work on the different layers. So most people aren't going to tolerate, you just going for it and, driving right through where things are most painful for them. You have to work on the soft tissues and the connective tissue layer, especially the fascia, which is what I like to call our body's natural saran wrap. Because it's from head to toe uninterrupted. And unlike saran wrap in your kitchen, you can't just toss it out and start over again. You have to find a way to unwrinkle it and kind of reset it with your hands, which is part of what osteopathic manipulative therapy can address and focus on. So, it's not necessarily going to be a one-time treatment thing. I usually treat once and then I give the body 3 to 4 weeks to reset. So the difference between what we do and what, say, a chiropractor does is that they are mainly based in the spine and off of business model. They want to see you 3 times a week for the rest of your life. I want to see you maybe 3 times in a year at most. So, you know, it's just really trying to get the body to enough time to heal itself, and, you know, operate at the most optimal functionality that it's capable of within whatever chronic pain realm or condition that you're dealing with.
I guess now we should get to some of the questions that we're getting. The one question we got was for somebody with say fibromyalgia. They're asking about the serotonin reuptake inhibitors and those types of medications that could be used for various different types of pain, but especially something like fibromyalgia. Is that something that you all use, the serotonin reuptake inhibitors?
So
I know sometimes I would like, sometimes somebody might respond to something like Cymbalta, which is an antidepressant, but also has good pain relieving qualities. So sometimes, you know, that does work for some patients.
yeah, Cymbalta and Lyrica, I'd say, are probably the biggest two that I see patients with fibromyalgia on. And like you said, it's to address that, you know, the mental health component of things, as well as the physical pain component. And, you know, in addition to that, I add on the osteopathic manipulator treatment, and as well as aquatherapy and an exercise prescription for them. I've seen patients do really well with a combination of those things.
Yeah, so I would echo in terms of fibromyalgia. Yeah, low impact aerobic exercise. Dr. Tamburello, you were talking earlier about like yoga. There's yoga with Adrian, which is a quick plug for that,
Yes.
which is something that I recommend for my patients to do.
On YouTube for, you know, there's a lot of resources
Yeah.
on YouTube for people to do yoga and other things like that. And you can do a short period of time. You can do 10 minutes, you could do 20 minutes. And so that's a good resource.
And touching base on some of the adjuvant medications, which are kind of the medications they were talking about for fibromyalgia. I think different people respond to different medications. I think, you know, one of the things that we've recognized is that physical pain and emotional pain end up becoming integrated in the central nervous system through one common relay, which is the thalamus. So you have a lot of the reason these medications, these adjuvant medications work well is that they work on modulating neurotransmitter transmission, whether it's through calcium channels and without getting too academic. But the point I'm trying to make here is that, so yes, Cymbalta is an SNRI that has been effective, and that it works for depression just because it works for keeping the serotonin and the norepinephrine in a sense, but it also works for pain because pain can be modulated by interneurons, and it has this common integration in our central nervous system. At the same time, I also use TCAs, which are tricyclic antidepressants. I'll use gabapentin and Lyrica. I'll even use sometimes some of our anti-seizure medications for the same reason that you get a seizure, because there's aberrant firing of neurons causing muscle movement. You can have aberrant firing of neurons causing your pain paradigm. And like I said, just kind of understanding that where you actually feel pain is in the brain. As much as, what ends up happening is you have this afferent neuron that goes up and crosses goes up 2 levels, crosses the spinal cord, but ultimately where you actually feel it is in the brain. And if you're able to either get it peripherally or get it centrally, if the patient is able to function better. So to answer that question, the answer would be yes, and there are different medications that may work for different people depending on what the etiology is.
And if you had somebody who was on, say, Lyrica or gabapentin, one of the questions was how long would you keep them on it if they're responding well? What are the upsides and the downsides to it?
So like for gabapentin and Lyrica, they're kind of similar. They're both like what we would call gabapentinoids. things you want to look at with a lot of these medications is they can make you tired, loopy, goofy, confused. So some patients will complain of some cognitive swelling. Sometimes the Lyrica and the gabapentin may precipitate a little bit of weight gain. So those are things you would be looking at. And if they're not working as well anymore. Now, I would say that if you look at any medication, there are some side effects. That doesn't mean that that's what has to happen in any particular individual's case, but it's, it's the things we look out for.
Mm-hmm. Okay. At this point, let me see if we had, trying to see if there were any questions that we might have missed. Let's see. And then I guess the question about the tolerance, I mean, just to kind of, I guess we had a question about tolerance, like what is tolerance? Just briefly, it's, sometimes if somebody's on a medication, say an opioid, if a certain dose was controlling their pain well, after time, an increased dose may be needed. And that's kind of what tolerance is. It's kind of like the body getting used to that medication or that dose of medication, so that the same dose that worked 6 months ago doesn't work now. And, either a different medication or a higher dose of that medication is needed. Let's see if there's any other, was there anything that Dr. Hyppolite that you wanted to add, or any other points that?
No, I think I just reiterate that, chronic pain is going to be experienced by everyone differently, and it really is an individualistic, approach in terms of treatment for it. Another thing too that we sort of touched on earlier was, just speaking with your physician about, goals and expectations, because a lot of times, the expectation at present may not match where that person is at present. So for example, somebody with, who just had, back surgery or something, thinking that they are going to go skiing, in a few weeks, and that's not the case. So just kind of having those educational sit down and talk it through is vital to the treatment outcome, in addition to whatever the treatment prescription is.
Another question that we got was, if you could create a dream regimen or dream drug to treat chronic pain, what would that be? I mean, for me, there is, again, like Dr. Hyppolite said, it's truly individual. It's not a one size fits all. For a lot of patients, it's going to be a combination of approaches. So maybe a medication for a certain period of time, or as needed for breakthrough pain or things like that. And then, the exercise program, acupuncture, ergonomics, if it's something like chronic back pain and somebody's sitting at a desk all day, sometimes there are adjustments that you could make in the workspace that can help. There are things like hypnosis, biofeedback, cognitive behavioral therapy. So it's not always a drug treatment, and it's not always, it's not a one size fits all kind of treatment. So that's kind of what I would say about that. I guess we're going to have to kind of wrap up soon. I guess that if people have any other questions, those can always be submitted, and we can address them and get back, get answers to people if there are any other questions that we weren't able to cover during this time. So what I'm going to do is I'm going to send it off to Dr. Anizelli, who's going to kind of close out our program this evening. I hope it was informative and everybody got something out of it. Dr. Anizelli?
Thanks so much, Dr. Tamburello. And so I'm Andy Iannizelli. I am a graduate of RowanSOM, class of 1995, and I currently serve as president of the Alumni Association. So I wanted to thank everyone for attending tonight. I know we switched the time of our webinars to a little bit later so that more people can make these webinars after their long day of work. So I know everyone's been at work and they come home and maybe grab something to eat even as we're doing the webinar, kind of, which is what I was doing as well. But I'm grateful for your attendance, and I hope the session was really helpful for everyone, and that it provided some wonderful guidance for you and may actually change the way you practice moving forward. Just so you all know, there's a recording of this session that's going to be available. It'll be posted on the RowanSOM alumni page by next week. So that's something you can look for if you want to review that again. And again, a special thanks to Drs. Tamburello, Dr. Hyppolite, Dr. Taylor, and student Dr. Chung. Thanks so much for sharing your time and your expertise with us. You know, I love the topic of pain management because it's so osteopathic at its core. It takes a holistic approach, a multifactorial approach. Oftentimes we have to think out of the box, which is what we as osteopaths are so good at doing. And so that type of approach, an osteopathic approach, is really ideal in treating chronic pain. You know, I think we mentioned medical marijuana. That's come up several times when we, as an alumni webinar series committee, started discussing topics that might be good to discuss in the future or for future webinars. That was something that came up again this evening. One of the questions was about medical marijuana. So I think maybe in the future we could have almost an entire webinar just dedicated to that. And it's such an up and coming, I feel like, at least as a clinician, I get asked about it more and more as it's gaining momentum in the legislative arena as well. So also thanks to the Alumni Webinar Advisory Committee who helped plan this series, as well as for the entire SOM team for your contributions that have made this webinar this evening possible. Nora has put up on your screen our social media slides. So if you want to stay abreast of all of the news and events and programs that are happening, please like us on Facebook and follow us on Instagram. Again, thanks to our panel for sharing your amazing fund of knowledge and expertise. And thanks to all of our attendees for taking time out of your busy schedules to join us this evening. I look forward to seeing you again in October, in 3 months, for our next webinar, and the details for that will be forthcoming in the next few weeks. So thanks everyone, be well, be safe, and have a great evening.
Thank you.
Thank you.
Take care.
Thank you both. Thanks, Natalie.
Thank you.
Have a good night.
You too. Thanks, Gail.